Assalamu alaikum, I'm Marwa Adil. In this lecture, we'll talk about gynaecological examination. As a good practice before any examination, to introduce yourself, explain the procedures and its indication, take a verbal consent from the patient to examine children and legally incompetent adults. Parental consent is required. A trained chaperone is mandatory. Don't use parents, friends, or relevant as chaperone. The examination must be in privacy and cover the patient throughout the examination. Prepare equipment before examination if any. Allied source should be available. Use non-sterile gloves for examination. The gyne examination includes general examination, breast examination, followed by abdominal then pelvic examination. To perform general examination, first we inspect for general appearance of the patient, build, nutritional status and stature, include development of secondary sexual characters. For example, breast development, pubic and axillary hair. Examine hand and mucous membrane for evidence of anemia or jaundice. Evidence of anemia, example for chylomicria, angular stomatitis, and atrophic glossitis. And for jaundice, we're looking for yellowish discoloration of sclera and mucous membrane. In general examination also, we examine teeth, gums, and tonsils for any septic foci. Neck examination by palpation of thyroid gland and lymph nodes, especially Virchow lymph node. Virchow lymph node is an enlarged left supraclavicular lymph node which indicate abdominal or pelvic malignancy that is spread via thoracic lymph duct. The breast should be examined as a part of gyne examination if indicated by history or pelvic examination. Particularly if the patient is suspected to have ovarian mass or ovarian cancer, as there is a link between breast and ovarian cancer called hereditary breast ovarian cancer syndrome, primarily through inherited mutated BRCA gene. Also, don't forget cardiovascular and respiratory system examination to assess either patient with comorbidity or patient with complication of gyne cancers. As a part of general examination, we inspect for peripheral edema, mainly in the legs, which is called beta edema. Vital signs is a part of gyne examination also. Examine for pulse rate, blood pressure, and respiratory rate. Don't forget body mass index, which is relevant in medical and surgical patient management. After general and breast examination, we examine abdomen. As a prerequisite, bladder should be empty. The patient lying semi-recumbent, covered, and all exposed from the sternum to symphysis pubis. The physician usually stands on the right side. Abdomen examination includes inspection, palpation, percussion, and auscultation if appropriate. By inspection, first for contour of abdomen, is it flat, scaphoid, or distended? If there is any asymmetry, visible mass, the skin condition of the abdomen, for example, presence of surgical scars, dilated vein, or striae gravidarum, which is a stretch mark of the pregnancy. Look for umbilicus shape. Is it inverted or everted? Normally, umbilicus will be inverted, and everted umbilicus can be normal anatomical variation or indicate increase intra-abdominal pressure due to obesity, fluid, pregnancy, or mass. Ask the patient to strain by raising her head or by coughing to examine for hernia orifice. An abdominal inspection and a surgical scar will describe its anatomical location, its shape and length, color, which is indicate maturity, and associated symptoms, example itching or burning pain. Inspection followed by abdominal palpation. Palpation divided into superficial and deep palpation. Superficial palpation, we examine for temperature, guarding, tenderness, and rigidity. while deep palpation for any mass and for organomegaly. Before proceeding for palpation, make sure your hands are warm and ask the patient from any area of abdominal pain. Any site of abdominal pain should be examined at the end, gently and looking for signs of protonism, guarding and rebound tenderness. Start palpation from left lower quadrant and clockwise to the right lower quadrant of the abdomen by palm of the hand rather than tips of the fingers. If there is an abdominal mass, describe its location, size in centimeters, consistency, mobility, and its surface. To differentiate between pelvic or abdominal mass, examine for the lower border of the mass if it is reachable or not. In general, lower border cannot be reached in pelvic tumors. To describe pelvic mass size, we compare it to gravid uterus. For example, the ovarian mass in a size of 20-week uterus. This means that mass reach the umbilicus, which stands for fundal level equivalent to 20 weeks pregnancy. In abdominal examination, in palpation we examine for inguinal hernias and lymph nodes. Abdominal percussion used to differentiate between mass, is it filled with gas, fluid, or a solid structure. The abdomen is generally resonant due to gas in intestine, while organs and fluid-filled structures produce a dull sound. Ascites, which is a free fluid collection in peritoneal cavity, in examination detected by shifting dullness and fluid thrill. How to percuss? Technique for percussion. Patient should be supine, knees slightly flexed to relax abdomen. Put the left hand flat on abdomen of the patient and using the tip of the middle finger of right hand to percuss on distal interpharyngeal joint of the middle finger of left hand. This procedure should be in zigzag pattern over all four quadrants. This is technique of percussion and this zigzag pattern over all quadrants. Percuss suprapubic region starts from umbilicus and down to symphysis pubis to evaluate any pelvic mass. For shifting dullness, it starts from umbilicus also and percuss laterally to the flank. In the flank, there will be dullness will be noted. Then, fixing that hand and ask the patient to turn to other side. By turning the patient to other side, dullness should be shifted, and this confirms free fluid collection on peritoneal cavity. Percussion also used for mass evaluation and assessing for organomegaly. This is a fluid thrill and this shifting dullness. Abdominal examination, as we say, inspection, palpation, percussion, and auscultation if relevant. Auscultation not routinely used as a part of gynae examination. Basically, auscultation reveals intestinal sounds, which is either hypoactive or hyperactive. Hypoactive in paretic areas and hyperactive in intestinal obstruction. In a pregnant uterus or fibroid uterus, there is uterine fall, which is synchronous with the patient pulse. Apart of that, fetal heart sound can be heard beyond 24 weeks. After abdominal examination, we proceed for pelvic examination, which is include inspection of external genitalia, inspection of cervix and vagina as a part of internal genitalia, followed by digital vaginal examination, palpation of the vagina and cervix by digital examination. Then, by manual examination, one hand vaginally and the other abdominally, so by manual examination. Rectal and rectovaginal examination if necessary. Patient commonly examined in dorsal position, lying flat on his back. Other positions, lateral or sems position, which is ideal for inspect anterior vaginal wall using speculum. Lateral position, which is lying supine with legs slightly flexed. It's ideal for examination under anesthesia. The position of the patient according to presenting complaint and physician choice. This same position, also called semi-prone position, in which the patient lie on their left side with extended knee and hip of the left lower limb, with slightly flexed right hip and knee. This is lateral position. The patient lies supine. In lateral position, the patient lies supine with hip joints flexed and abducted. Inspection of external genitalia as a part of pelvic examination starts with pubic hair distribution. External genitalia examine for any female genital mutilation type, which should be described. Any visible mass or swelling in the vulval area. Skin change, which include vulval and perianal area. Examine for any hemorrhoid, anal fissure, fistula, or perineal tear. The patient should be asked to cough or bear down, strain, to reveal any signs of genital prolapse or stress incontinence. All of these by inspection. Also inspect vestibule by separating labias using left hand. Note external urethral meatus, Bartholin ducts, and any vaginal discharge. Bartholin duct opening normally not visible and Bartholin not palpable unless blocked or inflamed. Inspect vagina and cervix using speculum examination, which is done prior to digital examination. The speculum is a medical instrument inserted gently to widen body passage or orifice. There is rectal, nostril, and vaginal speculum. In this case, using vaginal speculum, you use to visualize the vaginal walls and internal structure, example uterine cervix, to allow inspection and procedures. Speculum either made of metallic or plastic. There are two principal types used, couscous speculum and Sims speculum. To the right side is couscous speculum and to the left side is Sims speculum. Talk about couscous speculum. It's bivalved, has two blades, self-retaining instrument, has retaining screw that allows speculum to stay in place. Its blades looks like duckbill. While since speculum is non-self-retaining instrument, require assistant, it's used in left lateral position or Sims position, allow inspection of anterior vaginal wall and can be rotated to visualize other vaginal walls. Speculum used to visualize vaginal wall for examination of the cervix, to take high vaginal swab for bacteriological investigation of vaginal discharge, to perform pap smear as a part of screening program, in colposcopy, in small procedures, example, insertion of intrauterine contraceptive device, IUCD. Technique using speculum, put some warm water or lubricant on speculum, using left hand for separate labia, insert longitudinal, then turn into transverse position. The screw should be down if using couscous speculum. Complete the procedure and screw off to remove the speculum. After inspection of external genitalia and inspection of cervix and vagina using speculum, we proceed to digital vagina examination. Digital examination done using gloved index finger or index and middle finger, lubricated with sterile lubricant. Virgin patient with intact hymen can withhold this examination and do rectal examination instead of vaginal examination. In digital vaginal examination, it starts systematic with examine Bartholin gland and lateral vaginal wall by index and thumb, then palpate the vaginal wall from below upward to detect any abnormality. When reaching the vaginal portion of the uterine cervix, palpate to note its position, either anterior in retroverted uterus, which is abnormal position, and posterior cervix in anteverted uterus, which is a normal or usual position of the uterus. Cervical station It's usually used intrapartum to assess the fetal skull relative to pelvic bone, mainly ischial spine. Texture of the cervix in non-pregnant state is firm-like tip of nose. The shape of the cervix either conical or cylindrical according to variety of the patient. Cervical movement, is it painful or not? Painful cervical movement is called cervical motion tenderness or cylinder sign, which is indicate pelvic inflammatory disease or other pathology causing peritoneal irritation. During cervical palpation, note it's bleed to touch or not. Bleed to touch means friable cervix, which can be physiological or pathological. Physiological during pregnancy and when using pills, hormone contraception, and pathological in case of inflammation and malignancy. Following digital vaginal examination, there is bimanual examination to assess pelvic organs, right hand vaginally and the left hand abdominally. It starts with the cervix, as we say. Examine the cervix for its texture, position, shape, mobility, and tenderness. This is a bimanual examination using one hand vaginally and the other abdominally. After assess pelvic organs, starting with the cervix, then examine the uterus for uterine size, shape, position, mobility, consistency, and tenderness. Normally, the uterus is pear-shaped, about 9 centimeters or 7.5 centimeters in non-pregnant ladies, usually anteverted, anteflexed, freely mobile, and non-tender. Following uterine examination, examine lateral fornix, right and left, to palpate for adnexal, which is tubes and ovaries. Usually, normal ovaries not palpable, and if there is any adnexal swelling or adnexal tenderness, should be noted during bimanual examination. Following examination, fornices right and left, examine the posterior fornix for uterosacral ligament, which is involved in endometriosis. The uterosacral ligament is a common site for deep infiltrating endometriosis, which is implanted in that ligament, causing bleeding, inflammation, causing tenderness on the uterosacral ligament. In posterior fornix, also examine pouch of Douglas, which is called cul-de-sac, posterior cul-de-sac, and recto-uterine pouch. The pouch of Douglas is the lowermost part of the peritoneal cavity in which the fluid accumulated in case of PID, ascites, any peritoneal hemorrhage, and so on. Any pathology detected in pouch of Douglas should be supplemented by rectal examination. Rectal examination is not a routine part of gynae examination, used in some situations with additional consent. Occasionally, rectovaginal examination may be useful to identify rectovaginal septum. This rectovaginal examination, index finger in the vagina and the middle finger in the rectum, to palpate for rectovaginal septum, which can be involved in endometriosis, in fistula, and so on. It's less sensitive than vaginal examination, uncomfortable, but might be necessary in some cases. Indication of rectal examination in children or adult virgin patient: if the vaginal examination painful or vaginal vault inaccessible, in carcinoma of the cervix with perimetrial involvement or rectal involvement. Any pathology of pouch of Douglas during vaginal examination should be supplemented by rectal examination. Vaginal agenesis or atresia in a patient have rectal symptoms, also to diagnose posterior compartment genital prolapse, rectocele. This is the end of this lecture. Thank you.